So I think you should do ligament augmentation on patients that are undergoing more than 5 levels of fusion. Anytime you go up to the thoracic spine for a deformity operation, whether that be at the distal thoracic or proximal thoracic, or specifically in patients that you're doing a large correction on, or you're doing a significant alignment change. I typically don't use them in patients that are already fused, so in cases such as ankylosing spondylitis, where there really is no significant movement proximal to a fusion, I typically don't use it. I've used the ligament augmentation really only in the thoracic spine, either proximal thoracic or distal thoracic. So typically either T2, T3, or T9, T10 in those areas. My strategy is typically to go UIV +1. If it's a patient that has a fair amount of thoracolumbar kyphosis, and I'm concerned that I need to do a dissection potentially up to T8, those are cases that I probably am going to take up more proximal with my fusion construct anyway. But for the most part, I use it at UIV +1. Make sure that the hole at the spinous process is not too superficial, where the spinous process is weak. It needs to be lower down at the junction between the lamina and the spinous process. Typically, I place it in the upper third of the lamina. I usually use either a penetrating towel clamp or a right angle to complete the pass through the bone. One band typically passes easy. To get more than one can sometimes be a challenge. So making sure that the hole is big enough without compromising the strength of the spinous process can sometimes be a little bit of a challenge. But again, just after a few cases, I'm very comfortable with it. Yeah, so with the LigaPASS system, I'm using the tensioners to tension the band. I typically also manually feel with a nerve hook to feel that the band's adequately tensioned. And I think one of the potential pitfalls early on is over tightening. So that's something to keep in mind and be aware of. The position of the hole is very important, and then I usually make the ipsilateral hole, and then usually place usually my suction or some type of device to have a target to drill when I do my contralateral hole, because you're going to make your life a lot more difficult if those holes don't line up and are not symmetric. So the ligament augmentation procedure has changed my practice for patients with adult spinal deformity as a way to reduce the junctional stress above the upper instrumented vertebra. And I think that that's a very important thing to take into consideration when you're doing these operations. I think it's part of the answer. I think getting the patient's alignment right, choosing the right type of rods, but doing something to help that dissipate the forces above the upper instrumented vertebra, I think is an important part of deformity surgeons' practice.